Injuries of ankle and foot. Hello. Ankle injuries. Watt described ankle injuries for the first time in 1768. The ankle joint is made up of distal end of tibia, fibula, and the talus. It is bounded on either side by strong ligaments. Talotibial, calcaneotibial, plantar fascia. Posterior tibiofibular, posterior talofibular, calcaneofibular, anterior tibiofibular, posterior talofibular. Mechanism of injury: twisting injury while walking, running, sports, athletes, etc. are the most common mode of ankle injuries. Fall from a height. Ankle injuries are indirect injuries here brought about by the displacing talus. Ankle injuries could be due to adduction, abduction, or external rotation forces. Adduction force causes transversus fracture of lateral malleolus, tear of lateral collateral ligament, and fracture of medial malleolus. Fractures due to adduction force. Adduction force. Trimalleolar fracture due to external rotation force. Abduction force causes transverse fracture of medial malleolus, deltoid tear, and oblique fracture of lateral malleolus. External rotational force fracture of both malleoli and posterior malleolar fracture. Clinical features. Patient usually gives history of inversion injury following which there is a pain, swelling, deformity of the ankle. Movements are decreased. Drawer's test, inversion and eversion stress test may be positive. Radiograph, plain X-ray of the ankle, AP and lateral views of the ankle helps to identify the malleolar fractures. Treatment goals: anatomical positioning of the talus to obtain a joint line that is parallel to the ground, smooth articular surface. If these goals are not achieved, post-traumatic osteoarthritis results. For stable injuries, no reduction is required. Immobilization with only plaster splints till the swelling decreases, and then a below knee plaster cast is applied with foot in neutral position. Unstable injuries require reduction and immobilization in plaster cast. The commonly encountered unstable injuries are fracture due to external rotation. This is more common and can be managed both by conservative and operative methods. Conservative method: this consists of a reversal of the injuring forces by closed reduction and a below knee plaster cast application. A walking cast is applied after a period of 1 month. Surgical method: in these both the malleola are fixed. First, the lateral malleoli is fixed with pin or screws, and later the medial malleolar fracture is fixed with a single screw perpendicular to the fracture line. Below knee splint is given initially and later a cast is applied. Fracture primarily due to abduction. There are less common than the fractures due to external rotation, but however, the principles of the treatment remain the same. Abduction force is required to bring about reduction, and if closed reduction fails, open reduction is preferred. During the open reduction, both malleoli are fixed. Fracture primarily due to adduction. Unlike external rotation and abduction, adduction violence is more frequently an isolated event. Wedging of small comminuted fragments into the fracture line often prevents closed reduction, so that open reduction and internal fixation, or if is required, more frequently. Medial malleolus is approached first since it is more unstable and the fracture is fixed with two screws, one at right angle to tibial cortex, and another at right angle to the fracture line. Lateral fibular fracture is stabilized with plate and screws. To screw fixation of medial malleolar fracture. Plain X-ray showing fixation of medial malleolar fracture. Fracture resulting from primarily vertical compression. This may be isolated or associated with other forces described above. The anterior and posterior tibial plafond margins are fractured. Two types are described. Posterior marginal fracture. For undisplaced fracture, below knee cast is sufficient for more than 25% of articular surface involvement, or if with two screws is preferred. Anterior marginal fracture, tibial plafond injury. It may include a crush of the anterior lip, or it may include a major fragment. If crushed, calcaneal traction is given, and if there is a large fragment, or if is required. Complications. Complications of ankle fractures include post-traumatic arthritis, reflex sympathetic dystrophy, neurovascular injury, injury to the posterior tibial vessels and nerve, non-union due to soft tissue interposition, malunion, etc. Physiotherapy management of ankle injuries. Orthopedic goals to restore the ankle mortise back to its normal anatomy and to restore the position of the talus underneath the tibial plafond. Note, even 1 millimeter loss of articular congruity is unacceptable in ankle joint. Rehabilitation goals. Ideally, full range of movements should be restored back to normal. If not, at least functional level should be attained. Showing the normal and functional range of ankle movements. Movements, plantar flexion, normal 45 degree, functional 20 degree. Dorsiflexion, normal 20 degree, functional 10 degree. Foot inversion, normal 35 degree, functional 25 degree. Foot eversion, normal 10 degree, functional 10 degree. To regain the strength of the plantar flexors and dorsiflexors of foot and ankle, inverters and everters of the foot. Functional goals to restore the normal gait. Note, required time of healing 6 to 12 weeks. Required time of rehabilitation 12 to 24 weeks. Physiotherapy for ankle injuries treated conservatively. The cast is inspected for adequate padding. It is inspected for cracks, softening, breakage, etc. and is accordingly reinforced and repaired. During the first week, active exercises for the metatarsophalangeal joint are instituted. By second week, isometric quadriceps exercises are commenced. By 4 to 6 weeks, the cast may be changed to patellar tendon bearing PTB cast. During the same time, isometric quadriceps and ankle plantar dorsiflexor group strengthening exercise are commenced. After 6 to 8 weeks, the cast is removed. Active assisted range of movement exercises to the knee, ankle and subtalar and metatarsophalangeal joints are prescribed. Isotonic and isokinetic exercises to the ankle joint are also commenced. Self-assisted relaxed passive movements to the ankle and foot are also commenced after 8 to 12 weeks. Techniques of self-assisted passive ankle movements. The patient sits with the affected extremity crossed over the knee of the normal leg, grasping the foot with both hands. Fall range passive ankle and foot movements are carried out by the patient himself. Circumduction of the ankle also helps considerably. Caution should be exercised in not overdoing the passive range of exercises. Patient performing a passive ankle and foot movements during mobilization. Ankle circumduction can also be done passively. Adjunctive measures. Thermotherapy helps to reduce the ankle pain and edema. Calf muscle stretching exercises in the standing, step standing and sitting positions also helps considerably. After 8 to 12 weeks, progressive resistive exercises to the ankle joint muscles are commenced. Weight bearing. All ankle fractures are advised non-weight bearing with a 2-point gait in the crutches. The patient climbs the staircase one step at a time with good leg first and descends with the bad leg first. By 6 to 8 weeks, partial weight bearing may be allowed. Normal gait using a cane may also be allowed. If there is sufficient evidence of callus over the X-ray, full weight bearing may be gradually allowed by 8 weeks. Functional activities. Patient is taught to transfer weight using assistive devices such as crutches with NWB on the affected extremity. The patient should wear the trousers first with affected extremity and remove it from the unaffected extremity. By 4 weeks, toe touch to partial weight bearing is gradually allowed. By 8 weeks, the patient can dress with the affected limb first. Physiotherapy for ankle injuries treated surgically by open reduction and internal fixation. For rigidly fixed ankle fractures, active range of motion exercises to the knee, ankle and MTP joints, isometric quadriceps and ankle exercises are commenced during the first week itself. By second week, isotonic ankle exercises are commenced. Progressive resistive and passive exercises to the ankle and subtalar joints are started by the end of 8 to 12 weeks. Weight bearing, toe touch weight bearing for rigidly fixed fractures by the end of 1 week. By 4 to 6 weeks, partial weight bearing, and by 8 weeks, progressive weight bearing is permitted. FWB is allowed after 12 weeks. Quick facts. Ankle injuries. Aim of treatment is to restore the normal ankle mortise and range of ankle movements. For CAS, PWB by the end of 4 to 6 weeks. CAS is removed after 6 to 8 weeks. Self-assisted ankle passive movements are very effective. Calf muscle stretching exercises are very beneficial. All ankle injuries are non-weight bearing with a two-part gait using crutches. Partial weight bearing by 6 weeks and full weight bearing by 8 weeks. In rigidly fixed fractures, weight bearing and ankle movements are commenced in the first week itself. Ankle sprain. These are common injury in sports. If improperly treated, it may result in chronic laxity, pain, or delayed recovery. Lateral ligament sprain. This is the most common musculoskeletal injury with an incidence of 1 by 10,000 per day. In 85% of cases, it is due to inversion of a supinated plantar flexed foot. The lateral ligament commonly injured is anterior talofibular ligament followed by calcaneofibular ligament. The posterior talofibular ligament is rarely sprained, showing the lateral ligament sprain due to adduction injury. Clinical features. Patient complains of pain, swelling and tenderness over the affected ligament. Anterior drawer test is positive and it is performed by stabilizing distal tibia with one hand, then grasps the posterior heel with the opposite hand and applies anterior force. If the displacement of talus is more than 8 mm anterior, it suggests laxity of the anterior talofibular ligament. Next, the talar tilt is performed. If the tilt is more than 5 degree, it suggests laxity of anterior talofibular and calcaneofibular ligaments. Grading of ankle sprains. Grade 1, no laxity, minimal pain and mild swelling. Grade 2, mild to moderate laxity, soft tissue swelling, anterior drawer and talar tilt is slightly positive. Grade 3, severe swelling and pain. The anterior drawer and talar tilt tests are highly positive. Medial ligament sprain. This is due to pronation eversion injury. In mild sprains, only the superficial part of the deltoid ligament is torn, but in severe forms, the deep part of the deltoid ligament is also torn, resulting in a lateral talar tilt. If this exceeds more than 2 mm, significant alteration in the weight bearing mechanisms takes place, resulting in post-traumatic arthritis. For mild sprains, conservative treatment is sufficient, and for severe sprains, surgical reduction and repair is considered. Treatment of ankle sprain. Grade 1 sprain. RICE regimen, rest to the part, ice therapy, compression bandaging, elevation of the limb. In addition to the above, the following measures needs to be taken. Active toe exercises, NWB crutch walking, drugs like painkillers, etc. Grade 2 sprain, partial tear. Apart from the above measures, grade 2 sprains are further managed as follows. Strapping. This is given for 3 weeks. After 3 days, patient is permitted partial weight bearing with crutches. Alternatively, knee brace can also be used. Cast bracing allows early mobilization of the ankle. Long leg cast is indicated in partial or complete rupture of the ligament after surgical repair and is given for 3 to 4 weeks. After removal of the long leg cast, the following physiotherapy measures are suggested following surgical repair. To prevent adhesions, deep friction massage. To prevent pain, spasm and swelling, thermotherapy. For early mobilization, early relaxed passive ankle movements. Active and progressive resistive exercises are begin at the earliest. Intrinsic muscles exercises of the foot. Full weight bearing after 6 weeks. Ambulation and gait training. Once gait is regained, patient is trained to stand on the toes, heel, spot jogging, running, etc. By 8 to 12 weeks, patient should regain sports. Grade 3 treatment is essentially surgical and consists of exploration and primary ligament repair or reconstruction. The limb is then immobilized in a long leg POP cast for a period of 3 to 4 weeks. Later, mobilization is the same as for grade 2 sprain. Physiotherapy measures are the same as above but performed more rigorously. Fractures of the hind foot. Fracture calcaneum. Calcaneus is the most often fractured tarsal bone. No ideal method of treatment has been described yet. Calcaneal fracture could be extra-articular or intra-articular. Showing heel compression test for diagnosing undisplaced or stress fracture of calcaneum. Mechanism of injury. Twisting force cause many of the extra-articular fractures. Fall from height causes vast majority of intra-articular fractures. This is a common cause. Clinical features. Patient complains of pain and swelling of the heel, inability to bear weight on the heel. In undisplaced or stress fractures, patient complains of pain during the heel compression test. In grossly displaced and comminuted fractures, the swelling is more and the breadth of the heel is increased. Radiograph. Routine and special radiological views helps to make a correct diagnosis and the plan the appropriate line of treatment. The two angles of importance are Gesene angle and Bowler's angle, which will be disturbed in intra-articular fractures. These angles needs to be restored back following treatment. Showing Gesene angle and Bowler's angle. Treatment. Extra-articular fractures. Fracture of anterior process. Avulsion fracture. Short leg cast. Compression fracture should be reduced and fixed with K wires or screw. Fracture tuberosity, undisplaced fracture, short leg cast. Displaced fracture, open reduction and internal fixation. Fracture medial calcaneal process, undisplaced fracture, plaster cast. Displaced, open reduction with medial lateral compression and internal fixation. Fracture sustentaculum tali, undisplaced, plaster cast, displaced, open reduction and casting. Fracture of the body not involving the subtalar joint responds well to conservative treatment. Intra-articular fractures account for 60% of all tarsal injuries, and 75% of all calcaneal fractures. Intra-articular fractures of the calcaneum could be either undisplaced, tongue-shaped, or comminuted varieties. Treatment methods: undisplaced fractures can be treated by below-knee POP cast and is called the calcaneal cast. Tongue-shaped depressed fracture needs to be elevated with an axial percutaneous pin, and after restoration of the Bowler's angle, a below-knee POP cast is applied. Open reduction and internal fixation is sparingly done in calcaneal fractures. Management: the goals of treatment for calcaneal fractures are as follows. Orthopedic goals: to restore the length and width of calcaneum, calcaneal surface of the subtalar joint and the Bowler's angle back to normal. Rehabilitation goals: to restore the movements of ankle, subtalar and foot joints, to restore the muscle strength of plantar flexors, dorsiflexors, inverters and everters of the foot. Functional goals: to normalize the gait pattern. Note: required time for bone healing 8 to 12 weeks. Physiotherapy management for calcaneal fractures treated by Essex Lopresti method. The cast should allow full range of knee movements and should be up to the level of MTP joints. Active range of movements to the MTP, IP and knee joints is started during the first week. The limb is kept elevated to prevent edema. By the end of 8 weeks, active range of exercise is started to the ankle and subtalar joints after removal of the cast. From 8 to 12 weeks, active, active assistive and passive range of movements to the ankle and subtalar joint is commenced. Weight bearing. The weight bearing following calcaneal fractures should follow the protocol as shown below. Bed rest for 2 to 5 days with leg elevated. In a short leg cast, the patient may be allowed to toe touch weight bearing. By 2 to 3 weeks, partial weight bearing is permitted and allowed to continue for further 3 weeks. Weight bearing is done in the cast within 8 weeks following surgery. Weight bearing out of the cast after 8 weeks. Full weight bearing after 12 weeks of surgery. Functional activities. The patient is taught to wear the pant with the affected leg first and remove it from the unaffected leg. The patient is taught non-weight bearing crutch or walker, standing and weight transfer from bed to chair and vice versa. Physiotherapy management for calcaneal fractures treated conservatively with short leg cast. The physiotherapy proceeds on the same lines as discussed above, except that it takes longer time for range of motion exercises and weight bearing exercises to be commenced. Complications. Non-union is rare due to the cancellous nature of the bone. Malunion is more common. Heel pain. The source of heel pain could be from subtalar joint due to post-traumatic osteoarthritis, peroneal tendinitis due to stenosing tenovaginitis of the peroneal tendons, bone spurs due to malunion of fracture and disruption of fat pad of the heel. Arthritis of calcaneocuboid joint is a major cause of pain. Nerve entrapment is rare. Medial or lateral plantar branches of posterior tibial nerve or sural nerve may be entrapped due to soft tissue scarring. Fracture talus. Importance of talus: takes part in weight transmission, has a precarious blood supply. 3 by 5th of bone is covered by articular cartilage. Sudden hyperextension of the forefoot causes fracture neck called aviatus australis. Blood supply of talus: 60% is covered by articular surface. Only limited surface is available for vascular perforation. No muscle originates or inserts into talus. All the 3 major arteries of the foot supply talus. There is important contribution from capsular and ligamentous vessels. Blood supply of talus. Due to the above factors, Avascular necrosis of the talus following injuries is fairly common. Fracture neck talus. This is second in frequency to the chip and avulsion fracture of the talus. Incidence is 30%. Mechanism of injury. The common mode of injury is hyperdorsiflexion of the foot on the leg. It may be associated with fracture of tarsal bones and fracture of the metatarsal bones. Classification. It is classified into 4 types as shown in table. Types of fracture neck talus. Type 1, undisplaced vertical fracture neck of talus. Type 2, displaced fracture with subluxation or dislocation of subtalar joint. Type 3, displaced fracture neck with dislocation of the body of the talus from both ankle and subtalar joints. Type 4, displaced fracture neck with dislocation of the body of the talus from subtalar, ankle, talona, bicular joints. Of the ankle showing fracture of the talus. Clinical features: patient complains of pain, swelling, inability to bear weight, and loss or restricted ankle and subtalar joint movements. Radiology: routine and special radiological views helps to make a correct diagnosis of the talar fractures and helps to plan the appropriate line of treatment. Treatment: type 1, this is best treated by below knee plaster cast. Type 2, in this, close reduction is done by traction in plantar flexion and a plaster cast is put in equinus. If this fails, ORIF with lag screws is done. Type 3, in these, approximately 25% are open fractures. Debridement is done first and close reduction is attempted later. If unsuccessful, ORIF with K-wires or open reduction with lag screws is attempted. Complications: skin necrosis, infection, delayed union, non-union, malunion, avascular necrosis, post-traumatic arthritis, etc. are some of the well-known complications of fracture talus. Physiotherapy management of talus fracture. The goals of treatment of fracture talus are as follows. Orthopedic goals: due to the threat of avascular necrosis, a complete anatomic restoration in fracture talus assumes utmost significance. Stable fixation should be aimed for fractures of talar neck, body, and head. Rehabilitation goals: to restore back the ankle and foot movements to normal or near to normal, to regain the strength of inverters, everters of the foot, dorsiflexors, and plantarflexors of the ankle. Functional goals: to normalize the gait pattern. Note: required time of bone healing 6 to 8 weeks, required time of rehabilitation 12 to 16 weeks. The protocol of physiotherapy management for talar fractures is as follows. Physiotherapy management after conservative treatment: closed reduction and POP casting is advocated for minimally displaced and undisplaced fractures need just immobilization. Active exercises are prescribed to the MTP and IP joints by the first week itself. Active knee joint movements are started from second week onwards. By 4 to 6 weeks, along with the above exercises, small amount of subtalar and ankle joint movements within the cast are attempted. 8 to 12 weeks, the cast can be removed and active range of motion exercise to the MTP, IP, knee and ankle and subtalar joints are advised. Isometric and isokinetic exercises to the joints mentioned above also helps. Physiotherapy management for after surgical treatment for fractures treated by open reduction, internal fixation, active range of motion, exercise are started to the MTP, IP and ankle joints by the first week itself. By the end of second week, knee joint and subtalar joints are also included. By 8 to 12 weeks, active assisted and passive range of motion exercises to the ankle and subtalar joints are prescribed. Weight bearing, non-weight bearing is advised for all talar fractures and foot end elevation to control the foot edema. By the end of second week, in rigidly fixed fractures, Toe touch weight bearing as tolerated by the patient is advised using assistive devices. Partial weight bearing by the end of 4 to 6 weeks in rigidly fixed fractures. Again, in these fractures, full weight bearing is allowed by 8 to 10 weeks. For patients treated with cast, non-weight bearing is advised for a prolonged period and partial weight bearing is commenced only after 8 to 12 weeks. Functional activities. The patient is instructed to wear the pant with the normal leg and remove it from the affected leg. The patient is also taught non-weight bearing, pivot, standing and transfer with assistive devices from bed to chair and vice versa. Ambulation with assistive devices is taught. After 8 to 12 weeks, the patient is functionally independent. Therapist teaching the method of alternate floor squatting by keeping the fractured limb forwards in talar fractures. Additional measures. Shortened tendo Achilles is the bane of these fractures. This prevents the patient from his normal squatting. To counter this and enable the patient to squat again, two methods are recommended. Vigorous dorsiflexion and plantar flexion exercises are prescribed to regain early dorsiflexion. This enables proper squatting. An alternate method of floor squatting with the patient keeping the fractured leg forward so that the pelvis can be lowered more on the normal side is taught. Quick facts. Fissure protocol for talar fractures. The treatment of choice is open reduction and internal fixation to prevent AVN. For rigidly fixed fractures, early weight bearing and active or subtalar joint mobilization is advocated. Prolonged periods of non-weight bearing for non-rigid fixation. Modified functional activities for daily living. Alternate method of floor squatting is taught to the patients. Midfoot fractures. Midfoot consists of navicular, three cuneiform and cuboid bones with their intervening joints. This region of the foot is fairly susceptible to injuries. Midfoot fractures are depicted in flowchart 14.1. Mechanism of injury. There are three common causes of midfoot fractures. Twisting of the forefoot. This usually occurs in a RTA due to forced foot abduction, twisting injury. Axial loading of a fixed foot. This can happen in two ways. Fall on an extremely dorsiflexed foot. Here an axial compression is applied to the heel. On an extremely ankle equinus, here axial compression is from the body weight. Direct crushing injuries as in industrial accidents. Clinical features. Patient complains of pain, swelling, limp and inability to bear weight over the affected foot. Radiograph. Routine foot x-rays including the AP and lateral views helps to make a correct diagnosis. Treatment goals. Orthopedic goal to restore the keystone of the midfoot, that is the first and second metatarsal articulation with the medial cuneiform, as it provides stability between the midfoot and forefoot during gait. To maintain the medial longitudinal arch of the foot by restoring the length and alignment of the cuneiforms, cuboid and navicular bones. The longitudinal and transverse arches should be maintained as they control the direct distribution of weight of the body or the foot during gait to restore the Lisfranc joint complex. Rehabilitation goals to restore full range of movements to the foot and ankle or at least the functional range. To restore the motion of the fourth or fifth metatarsal cuboid joints as greater degree of dorsiflexion, plantar flexion, pronation and supination takes place here. To restore the normal muscle strength of inverters, everters of the foot, dorsiflexors and plantar flexors of the ankle. Functional goals to restore the normal gait pattern, to maintain the longitudinal and transverse arches of the foot. Note, required time of bone healing, Lisfranc joints 8 to 10 weeks, cuboid, cuneiform and scaphoid bones 6 to 10 weeks. Required time of rehabilitation, Lisfranc joint 8 weeks to 4 months, cuboid, cuneiform and scaphoid bones 6 weeks to 4 months. Methods of treatment. Less frank injuries. Undisplaced fractures are treated by a short leg cast for 6 weeks. Displaced fracture is treated by open reduction and rigid internal fixation. For bone injuries, closed reduction and percutaneous pinning are very effective. Showing less frank injury related to tarsometatarsal joint. Navicular, cuboid and cuneiform fractures, dorsal lip fractures, tuberosity fractures and stress fractures of navicular bone, undisplaced fractures of the cuneiform and cuboid bones are treated by short leg cast. For intra-articular navicular bone fractures involving both talonavicular and naviculo-cuneiform joints, non-union and stress fractures are not responding to conservative treatment, require open reduction and rigid internal fixation. A nutcracker fracture requires either external fixation or open reduction and rigid internal fixation. Physiotherapy management for midfoot fractures. During the first 2 weeks, active range of motion exercises to the toes and MTP joints, no strengthening exercises to the ankle and foot, partial weight bearing for the avulsion and tuberosity fractures of the navicular bones, avulsion and undisplaced fractures of the cuboid bones. The remaining fractures are all non-weight bearing. By second week, isometric exercises to the dorsiflexors, plantar flexors, inverters and everters of the foot are started. Active ankle movements are begun. After 2 weeks, by 6 to 8 weeks, gentle active, active assistive and passive range of motion exercises to the ankle and subtalar joints are started. Isometric and isotonic exercises to the ankle and subtalar joints are advised. Partial weight bearing may be allowed for less frank injuries treated by either cast or close reduction and percutaneous pinning, cortical avulsion, tuberosity or stress fractures of navicular bones, undisplaced and avulsion fractures of cuneiform and cuboid bones. Rest of the fractures is non-weight bearing. After 8 to 12 weeks, gentle resistive exercises to the dorsiflexors, plantar flexors, inverters, everters, long flexors and extensors of the toes. Full weight bearing may be permitted for less frank fractures treated by cast or close reduction and percutaneous pinning, navicular fractures with cortical avulsion, tuberosity and stress fractures, undisplaced and avulsion fractures of the cuneiform and cuboid bones. Partial weight bearing of the other